I've always been interested in the how surgery is performed, and looking at outcomes of surgery. And as part of that, I've also become interested in the cost and the effectiveness of the surgical services that we deliver. We've been on a journey where we've been introducing patient level costing into Alder. When you clicked on our department, which is general surgery, there was an appropriately black-coloured black hole in our finances, which was appendicitis. And that was a surprise to all of us because we've done a lot of research into appendicitis, we've done lots of patient surveys, and we've had an almost forensic attention to trying to make the pathway that we treat children with appendicitis as effective as possible. But what had been missing was our financial side, and that was what became obvious. Having the financial information is really helpful because it lets us see where our challenges are. So, for instance, when we look at appendicitis, it became obvious that we needed senior decision makers involved because lots of children were waiting too long for surgery. Have we solved that completely? No. But what we have done is we changed the way we worked so that we then had a senior clinician who was freed from elective duties, so not doing clinics and theatres. And we opened a surgical decision unit, which meant that children and their families could be seen by a consultant as soon as they arrived in the hospital, rather than seeing lots of people who weren't able to make a definitive decision. By doing that, we got really good positive feedback from parents, and we improved the journey for the child, and we started to see inroads in our emergency lengths of stay and things like that. Because quite often, if we don't, for me as a surgeon and as a manager, if we've got a child who's an emergency in the who needs to go for an operation, and they're sitting in an emergency bed, the time from being ready to go to theatre to going to theatre, we are just hosing money. We're just losing money, and we're not actually treating the child either. So by having that focus on the financial side, it lets us see those clinical imperatives, so the two are really closely joined. The costings information was vitally important in building the business case for opening the surgical decision unit, in that we were able to use that data to model what the change would be if we performed better than we were. And things like that time from admission to theatre were key indicators that we could then use to show that there were improvements. One of the opportunities which having really effective patient level costing is that the quality of data in the NHS goes up massively. And so as the lead for the Getting It Right First Time project, my other job is looking at it from a national perspective and trying to pull that data and benchmark it. And there's a huge opportunity there in terms of seeing how different methods of care can result in different resource utilisation. So examples which I've seen are use of specialist nurses looking after babies who have undergone newborn surgery. The systems where they've used those specialist nurses, you can see that the total healthcare resource cost in the first year is much less than when those nurses aren't there. So an investment can actually cause a system level change. The other thing that you can see by having very accurate data is variation nationally, and that's sort of at the core of the Getting It Right First Time process. So you can see variation both in terms of resource utilisation, lengths of stay, use of day case surgery. You can see where evidence-based surgery isn't being performed. You can see areas where there's a gap in research to inform us about which is the most effective treatment. So there's loads of reasons we can use this data that I think will transform the way NHS care is delivered. I think from the clinician side, you need to not be frightened about the data. I think a lot, and you need to know that nothing terrible is going to happen to you when you see this data. It is just data at the end of the day. But you also need to be open to the fact that it will not be accurate, because quite often the initial data set has been built up without very much clinical input. So when you start to go into that data, and the data is, you can go down to individual patient level, and we found that very useful So where we've seen anomalies, we've gone down to that individual patient level and opened up the records to see where the issues are. Very often you'll find there's a coding issue, or some assumptions have been made that are incorrect. But by working with the people in the finance department and in the coding department, you can solve those problems. And once you've solved that problem, then it's solved. And you see then that you start to develop more faith in your data.